In fact, these founders of the hospital were setting up the hospital, and Dr. Ajay Khania being my schoolmate, batchmate, friend, and they actually wanted a cardiology setup to be put up in the hospital. And so I had to divert my energies for the last couple of years, 1.5 years actually, to set up the cath lab, the cardiology department itself. So it was very interesting. Dr. Amit is a cardiologist from DMC Ludhiana. He's a gold medalist, a bright young cardiologist with 4 years of cardiology cath lab experience with him. And he met me, and we wanted to plan. So for a change, then we wanted to. I actually went around with him to various centers in the country for the lookout of a cath lab, and try to. The first time actually, I never had time to see a live cardiac angiography, and actually I saw it, and that happened. I actually analyzed all the machines, Siemens, the GE cath labs, and Philips, etc. They are the three major cath labs. So the first one I saw was a GE lab in Delhi, and I was surprised. I told him, see, when we do like ERCPs, and we put the contrast in the common bile duct, and we or penetrate duct less often, but the contrast holds there, it stays there, and we have enough time to see if what we want to do, where is the stone, where is the stricture, how long is the stricture, where we want to put the stricture, the stent, because the contrast stays there, and it's an intraductal contrast, it's not even intravascular contrast. As opposed to that, when you look at a angiography, you inject the contrast, and contrast just washes off in a second. I mean, it comes and goes, it comes and goes. You start seeing it first time. I said, how do you remember where is the narrowing, how long is the narrowing, and whether the side branch is there? So this was, I grossly the issue in the very beginning, but for many years, then gradually the cath labs came up to have the ability to remember the messages, store digital photographs, etc., and try to minimize radiation to the healthcare worker, radiation to the patient, reduce contrast usage. Many cardiac patients could be sicker patients. We don't want to block their kidneys out. So I thought things were incomplete. So gradually I learned that the best cath lab machines actually look after all these factors. We don't want to load the patient with contrast. If we want to do a therapy, then we should remember to have a good roadmap. So at that time, when we were looking at this Philips Asurion, which is the latest cath lab machine in the world, so they introduced another software called Digital Coronary Roadmap, DCR. That for the first time, and we got that DCR as well. So it minimizes the radiation because we don't have to look at the pictures again and again, and it stores there, and we can just know what to do there. Other things he will touch upon, but I just want to say is, when you look at a routine angiogram, you really will not like to have yourself done on a lesser machine or lesser software. You want to have not only the angiogram, you want to have what is called as the intravascular ultrasound. So that's nearly 40 to 60 megahertz sharp image through the same catheter. You want to go to the coronary and see how much it's blocked. So anatomic detail, and it can also give you functional detail, how much is the gradient across the stricture. So you know exactly, yes, this person needs a stent and needs it there. So there's no guesswork. So that is where the modern cath lab is evolved to, and where it is now, and it is with us. I'll just put up a few things on this. They are the things we have, and there are things we have set up. And obviously, this particular cath lab, I just want to emphasize, is the first cath lab of this standard and facility in the state. To my date, there's no second one put as yet, and I think Dr. Amit will highlight more about this. But there's a few things I just wanted to make out, and maybe you can talk about the other facilities which you can provide with that. So I got involved, though I'm a gastroenterologist, but with my critical appraisal of the whole level of angiography. So we took it to a whole new level, and he took it positively. He wanted that equipment, we went ahead with it. So with this, I think I'll ask Dr. Amit to have a talk about what is the scope of the cardiac problems and services, and to what extent we can carry that. So, Dr. Amit.
So, good evening everyone, and thanks for a very nice introduction for the cardiology services of our hospital. No what I couldn't explain much better than you, so I'll be just jumping onto the topic directly, and then we'll keep on discussing. So I want it to be an interactive session. If you have any queries, you can always stop me in between and ask your questions, or if not, we can maybe have those questions at the end of the lecture. So STEMI, we already know it's a very huge problem in India, South Asia. So just touching on the various updates which have come down in the STEMI management. So we know acute coronary syndromes are a spectrum of conditions which are due to the abrupt reduction in the blood flow to the coronary circulation, and which can cause ischemia and infarction. And we have NSTEMI, NSTEMI, and nothing new in this. We have been taught from our medicine days what is the problem where that is going on when your the story of remodeling is going on. When we have minimal CAD, you have compensatory expansion of luminal of the normal artery. But when this luminal encroachment overcomes the expansion, you have a severe CAD, and then patients start having symptoms. Okay. So this is a very old slide from New England Journal of Medicine. We already know from our pathology classes. There is a lipid-rich macrophage pool. There is stress. There is tensile strength, and there are shear forces. But if there is a fissure development in that, you can have a coronary thrombus. If it's a large fissure, it can include the whole coronary artery. But if it's a small fissure, you will have a mural thrombus, and it can produce unstable angina and non-cuvous coronary myocardial infarction. So this is how do we see just in a nutshell unstable angina, NSTEMI, STEMI. Unstable angina is ischemia without necrosis. NSTEMI is necrosis which is transmural, non-transmural. And in STEMI you have whole transmural crossing, which whole of the muscle is involved. And you can have negative biomarkers in unstable angina, while in NSTEMI you have positive biomarkers. There is no ST segment elevation in unstable angina, and in STEMI these are the basic knowledge from our MBBS days. And there is ST segment elevation in STEMI. And treatment is always invasive or conservative depending upon the risk. There is a risk score called risk score we calculate in cases of NSTEMI. And in obviously in STEMI you need an immediate treatment perfusion. So what is the epidemiology? This is very important to talk. This has been taken from a recent paper that came in Lancet in the month of February this year. It's a very good paper. I request the audience to please have a look at this. So it is the leading cause of disability in the world, and it is responsible for around 31.8% of all deaths and 14.7 disability adjusted life years in the year 2017. That's the recent data we have. And according to the global rare disease burden, there are estimated 422 million prevalent cases of CVD in 2015, and obviously the largest contributor is the South Asian region. The Indian scenario. We don't want to talk about the world. We want to talk about India as we're staying here. So this is a Lancet publication, Southeast Asia, the burgeoning cardiovascular disease epidemic in Indians. What are the perspectives on contextual factors and potential solutions? As of the year 2017, CVD was responsible for 26.6% of the total deaths and 13.6% of the dialysis, which if we compare with 1990, it has doubled. In 1990, it was 15.2% deaths and 16.9% dialysis. and there is a 2.3-fold increase between 2 decades. So that's a huge burden of cardiovascular disease in India. Why CVD is different from the rest of the world? What are the peculiarities and differences? We have a high relative risk burden. We have an earlier age of onset, probably 10 years earlier than the Western counterparts. We have higher case fatality and we have higher premature deaths. So this is the things they found out from the Indian scenario. What are the changes going on in Indians? There are population level changes. There is increased biological risk. And there are 6 major transitions which are contributing to the increased prevalence of heart disease in India: epidemiological, demographic, environmental, social, cultural, nutritional, and economic. Economic in the sense we are becoming more modernized, we are becoming more sedentary, more bound to our computers, desk job. All these things are contributing to the social, cultural, and economic changes. Nutritional, we already know our diet has been on a more of these days away from plant-based diet to more of a meat-based diet, more of processed foods, more of salty foods. Environmental factors, that's a new factor that has come up. Air pollution. These days we are talking about air pollution since it has been found that it has caused changes in the endothelium, lipid peroxidation, so it is contributing to the increased amount of heart disease in India. Demographic, since the age expectancy is increasing, now we are already getting increased amount of heart disease prematurely, and of course epidemiological in the sense we are having more of non-communicable diseases as compared to communicable diseases. So these are the risk factors we already know. Some are non-modifiable, some are modifiable. Non-modifiable, we cannot help it. Increasing age, male gender, family history, genetic abnormalities. And potentially controllable are hyperlipidemias, hypertension, cigarette smoking, diabetes mellitus, and C-reactive protein. And less or certain risks are stress, type A personality, physical inactivity, high carb intake, lipoprotein A, and high trans fat intake. So it has multiplicative effects. 2 risk factors increases your CAD risk by 4-fold, and 3 risk factors increases the risk of MI by 7 times. These we already know. What are the common heart attack warning signs? Pain in the chest, lightheadedness, jaw, neck pain, discomfort in the arm or shoulder, or shortness of breath, and we have also angina on exertion. So nowadays we are following this, the 4th universal definition of myocardial infarction that came out in 2018. It divides the myocardial infarction into 5 types, that is type 1 to type 5. I'll be just touching upon them. They have also differentiated 2 concepts. They have come up with 2 concepts. What is myocardial injury and myocardial infarction? In myocardial injury, you have both of the things. You have raised troponin levels, but in myocardial infarction, you have objective evidence in the form of ECG changes, echocardiographic changes, and angiographic changes. So this is the change they have brought up. So as we can see in this diagram, there is hypoxemia, hypotension, kidney disease, heart disease, and ventricular arrhythmias, anemias. They all increases troponins, but there is no objective evidence on the ECG. But when you have objective evidence of on ECG, echo, or angiograph, it quantifies for myocardial infarction. So what is type 1 MI? Type 1 MI, there is plaque rupture with occlusive thrombus, and there is a plaque rupture with non-occlusive thrombus. And you have symptoms of ECG changes, pathological Q waves, imaging evidence, with new loss of viable myocardium, and identification of a coronary thrombus, including intracoronary imaging or autopsy. This is type 1 MI that we routinely see in our routine cases. Then type 2 MI is due to oxygen supply and demand imbalance. It could be due to accumulation of this one, atherosclerosis. Then you can have vasospasm, VC vasospasm, sorry. Then you have non-coronary atherosclerotic dissections. Can you see this? There is a rupture in the tunica intima, causing accumulation of blood in the intimal layers, and then of course oxygen supply demand imbalance. It could be due to atherosclerosis, coronary spasms, artery dissections, tachyarrhythmias, bradyarrhythmias, respiratory failures, hypertension, severe anemia. All these causes oxygen supply and demand imbalance, and patient develops myocardial infarction. Then type 3 when who patient suffers sudden cardiac death, but we could not get any cardiac biomarkers or and patient suddenly died. So we can assume based with symptoms suggestive of myocardial ischemia, we had new ischemic changes in that patient qualifies for type 3 MI. Type 4 is of course procedure related. If we do a procedure, we put a stent and post-procedure patient develops myocardial infarction. It could be in three categories: 4A, 4B, 4C. 4A is when there is a new development of new lesion in any other branch of the coronary artery. For example, if you put a stent in LAD but your L6 gets blocked or new blockage comes elsewhere, then it is type 4A. Type 4B is when your stent has thrombosed, and of course type 4C is when it associated with stent restenosis. Your stent has not fully expanded and it has got restenosed, so it qualifies for type 4C. And type 5 is post-CABG associated MI. So, sorry. This we already know. We might not go into details. The criteria for ECG ST elevation, we already know this. So this is the basic revision. Just skipping on to the slides. So inferior leads involve 2, 3 AVF, anterior leads involve V1, V2, V3, V4, and lateral leads involve 1 and AVL. So this is an area how to divide the infarctions. So as we can, whereas STEMI, this is anterior and lateral, we can see the 1 and AVL ST elevation, and of course V1 to V2 to V4 there is gross ST elevation. Here it is inferior wall with RV involvement, as we can see ST elevation in V1. Can anybody guess this? What is this ECG? Can anybody make a diagnosis? It's a very, we see in our clinical practice. Maybe physicians can make a diagnosis. Anyone? Any other guesses? Sir, Dr. Samantha? So this is everywhere. Pericarditis. So when you have ST elevation in all the veins, you tend to have a pericarditis with PR elevation. You can see the in-lead area. So it's a very common thing, right? Coming on to this slide is very important. You must not miss these life-threatening equivalents which are there. Conventional STEMI, we know ST elevation. We have what is called Deventer syndrome, in which we have ST depression in lead, and along with that we have peak T waves. Okay, it is usually seen in V1 and V2. Posterior SEMI, we already know when you have tall R waves in V1 to V2 along with ST segment depression. Balance sign A and B needs to be picked with very astute eyes. Normally, patient will not complain of any chest pain, but they will have biphasic waves in lead V1 and V2. So you should be aware of this. Then normally in these patients, LAD is occluded. Then we have hyperacute T waves. These we already know. Then in cases of LBV, we apply Scarboza criteria when to identify ST elevation MI. Sharp fin appearance is also a very dangerous sign in which patients usually have a very bad prognosis. And of course, when you have LVH, you have more than 25% elevation of the preceding QRS complex, right? So STEMI is always a priority. If a patient comes to any emergency and you are dealing with so many patients, STEMI needs the priority since we are dealing with a life-threatening situation. So we should leave all other patients and take note of this STEMI. So as soon as patient enters the emergency, ECG should be done within 10 minutes. That is very important. Take a brief clinical history. You don't have to spend time 20 minutes. How do you feel? How the symptoms begin? You have to rule out other things like cancer, strokes, and bleeding also. This history is very important in deciding whether you want to send for a patient for a fibrinolytic therapy or a primary PCI. If you know all these things, if there are contraindications, you cannot give a fibrinolytic therapy to the patient. So that is very important. We already know from our MBS days MONA, morphine, oxygen, nitrates, and aspirin. So nothing new in this. We have to do this as soon as the patient comes to the emergency. So now we have to decide whether we want to send the patient to a primary PCI center or a fibrinolysis pathway. This is to be decided depending upon how much time you have when a patient comes to you, whether you can send it to a lab which is within 120 minutes, 2 hours away, or the patient will take more than 2 hours. If patient will take more than 2 hours to sending to a cath lab, you can go ahead and do a fibrinolysis. But if time is less, patient can make it to a cath lab within 2 hours, we always prefer sending to a primary PCI center. So door in to door balloon time means if you are coming in as primary PCI center, coming into the emergency and coming out of emergency should be less than 30 minutes. Within 30 minutes, patient should be out of the emergency in the cath lab. And of course, in a fibrinolysis pathway, when patient comes to you and you know that patient will take 2-3 hours, obviously within 30 minutes, patient should be thrombolized. So this is very important. This has to be kept in mind. This is a very important slide. Every 30-minute delay will increase the 8% increase in 1-year mortality. So we cannot wait and think, okay, we'll do something. As you can see in the diagrams, as the time is passing away, the mortality is increasing. So there is an adage word in our cardiology, time is muscle. This is very important. You have to just act very quickly and move forward. I want to spend time on this slide. This is a very important slide. Nowadays, what we are following is a hub and spoke model. Okay, your hub hospital is a PCI center and spoke are the peripheral centers. Okay, if a patient is done if a diagnosis is made a non-PCI center, then as we discussed, the semi-diagnosis should be made within 10 minutes, and if it's time to FMC means first medical contact. First medical contact to PCI is less than 120 minutes. If it is a yes, transfer to a primary PCI center and should be first medical contact to primary PCI should be done within 2 hours. And if it's not, we discussed should be done, the fibrinolysis should be done in 30 minutes. Nowadays, they have come up with the concept of a pharmaco-invasive strategy. What they do is in the pharmaco-invasive strategy is that they thrombolize at the periphery. If they know that patient cannot make it to the primary center, they will thrombolize it. They will inform the cath lab, and cath lab will be activated, and PCI has to be done within 12 hours, within 12 to 24 hours. So that is a pharmaco-invasive strategy that is being followed for a rural setup when patient cannot make it to the cath lab. Okay. And of course, if it's coming to a hub center, primary PCI has to be done within 90 minutes. So this difference has to be noted down. Obviously, we start aspirin, we give loading doses. One thing I want to stress, still in our periphery and government hospital, loading dose is being done with clopidogrel. There has been numerous trials which have been shown that ticagrelor loading is much better than clopidogrel. It has a consistent antiplatelet effect, much better than clopidogrel. So I would request, and I will request the audience, probably the physicians, whenever a STEMI patient comes to you, kindly avoid loading with clopidogrel. Since anyways, if a patient comes to a cath lab, we'll have to give a ticagrelor. So there is no point giving a clopidogrel in the periphery. Better to give a ticagrelor as it has a consistent antiplatelet effect. So these are the 3 loading doses: clopidogrel, prasugrel, and ticagrelor. We as a cardiology don't prefer much of clopidogrel. We go with the prasugrel or a ticagrelor. Only thing has to be taken in thin patients and elderly patients. Don't give prasugrel. Go ahead and give a ticagrelor. Dosage is 180 milligram loading dose. This we have discussed. Ticagrelor has been found to be much better in all the trials, and it has a faster action, greater action, and more consistent platelet inhibition than clopidogrel. Fibrinolytic therapy we discussed. There are criteria of ST segment resolution on ECG when we give fibrinolysis. It should be less than 70%, and these are the agents we use. We all know streptokinase, an old age agent, but the problem with streptokinase is it is very fibrin non-specific. So there are risk of intracranial hemorrhage with streptokinase, and it has to be given over a period of 1 hour. Nowadays, we prefer giving tenecteplase since it is just a bolus dose, and it is highly fibrin specific, and the patency rate of opening with rectum raise is 85%. So rectum raise is much better as compared to streptokinase. And yes, they do feel, since we have to give a heparin during the procedure, there is increased chance of hematoma formation at the procedure sites if you go it with femoral and all these things. So generally, this is only in patients in the periphery, not when you can get an access to a primary PCI center. So these are the contraindications I was talking about. You should know absolute contraindication to fibrinogen therapy is recent intracranial hemorrhage, cerebral vascular lesions, stroke, neoplasm intracranial, aortic dissection, active bleeding ulcers, significant head injury within 3 months, recent intracranial or spinal injury, and of course severe uncontrolled hypertension. These are absolute contraindications where you will not give a fibrinogen therapy and prefer the patient for a primary PCI. So PCI is the gold standard in STEMI management. We already know this. Numerous trials have been done, and they have been found that it has PCI was associated with long-term reductions in mortality and brain functions. And if all these trials are reinforcing primary PCI is much better than a fibrinogen therapy. These are the pharmaco-invasive strategy I talked about, where we give a fibrinotic agent in the periphery and we do a primary PCI within 24 hours. Other facilitated PCI we generally don't do these days, and rescue PCI is done in which you have a failure of a thrombolysis. Again, this we have discussed time to achievement of the goals. Total time taken from the first medical contact to for primary PCI should be less than 90 minutes. This we have discussed time to FMC to coronary angiography should be less than 24 hours. Now comes the role of IVP. We have procured IVP in our cath lab. Why IVP is important in a cath lab? It provides an acute circulatory support, right? In patients of cardiogenic shock, where if we give inotropes, they have undesirable side effects of norepinephrine, dopamine, and all these things. These things, the circulatory support avoids that side effects, maintains vital organ perfusion, it reduces intracardiac filling pressures, it reduces left ventricular volumes, it increases coronary perfusion, and it supports the circulation during complex interventional procedures. So it acts as a game changer for the cardiology. Cath lab, we can do all our complex procedure under support of an IVP. So certain cases I'll be sharing which we have done in our cath lab over the last 6-8 months since the inception of the cath lab. So this is a 50-year-old gentleman presented to us with complaints of chest pain 8 hours prior to admission. His BP was 130/80 and his heart rate was 110 per minute. ECG, as you can see, it is a classical of posterior wall MI. You can see ST elevation in lead 2, 3 and AVF. Along with that, you can see ST segment depression in V2 and V3 with tall R waves. So we took the patient to cath lab. We did an angiogram. We took a first shot and boom. You can see this. There is absolute cutoff of this artery. So this is a left circumflex artery, and here you can see LED is okay. Right coronary artery was absolutely fine. So as soon as we passed down the wire, the flow started coming in left circumflex. We ballooned it. Again, the flow restored. We placed the stent, and we optimized the stent, and this was the final flow post stenting. And you can see the drastic changes in ECG post PTC. All the ST elevation has gone. 2-3 AVF has become normal. ST segment depression has gone in posterior wall. So
I just want to know for you to tell everybody how the stent optimization is actually done.
Right, we'll go there. Okay. That is very okay. Isolated posterior. RCA was not there. So this is another case. This is a middle-aged gentleman. Can you see here? This is huge ST elevation and 2-3 AVF. We took the patient to a cath lab and left system was fine, and see right coronary artery. Here you can see absolute no flow in the right coronary artery. And then we passed down the wire, flow immediately came, put a stent, optimized it, and of course the flow, it was a huge right coronary artery, and of course ST segments, resolution came down and patient was doing well. 80-year-old lady again, chest pain since 2 days. She presented was pretty late. You can see ST elevation along with Q waves. Took her to cath lab, and you can see and clot is sitting in the LED. Can you appreciate the clot here? Right was fine. You down the wire, ballooned it, put a stent, and optimized it, and the flow was restored.
Like, how did you say if the water is not well? We're not.
This is a clot. I'll come up. Have some patience. Okay, this is a young male, 42-year-old. He was complaining of some vague symptoms. Can anyone help me in this ECG? Can anyone make a diagnosis in this ECG? It's a very basic ECG. He was complaining of some vague chest pain and all this things. I would appreciate the answers from the audience. Okay. Can you see a V2 and V1? I just discussed that it is well in can biphasic T waves and all these things. And subtle changes in 2, 3 and AVF. You can see some slides, ST segment raised in 2, 3 AVF. So it was pretty confusing to us. We thought he's complaining of vague complaints and all. So we made a decision, okay, we'll check in a cath lab. But to our surprise, this patient had no flow in the area. Can you appreciate? There is no flow in the area. It is only LC that is flowing. And then to our utter shock, patient had no flow in the right coronary artery also.
What's the message?
I'm just telling you. Patient is 42-year-old man is just living on a single artery. Pretty strange. So we down the wire in the right coronary artery. Okay, and balloon extended it. And you can see the results. And you can appreciate this is a huge artery supplying the left system also. So we completed one and after a week or so we did the LED also. This is a 29-year-old when he came to us in the month of January, and this was his ECG presentation. Can you appreciate the way clots sitting right in the LED artery? Okay, then we did our procedures and ST segment came down and it was fine. Again, another case from Tourism, this patient came to us, RC was completely blocked, stent was placed. So these are the few examples which I shared you. So what is the role for state-of-the-art cath lab and efficient heart rate? How does it help us? Efficient heart rate should be on emergency service 24 hours a day, 7 days a week. You cannot just say that we will do this case in the morning, okay, patient is fine, we give him some painkillers and all this thing. This is practice has to be reported. If a patient is presenting you in the middle of the night, 12 a.m., you have to be up in the cath lab and do the procedure. So it has to be that considered efficient. Our team, here we did, our team is doing the procedure at the middle of the night, and of course post procedure all happy faces with the cath lab with the background. So that constitutes an efficient art team that can make informed decisions. So I was talking about this feature, dynamic coronary roadmap. What is this? This feature is not available in this region. We have acquired this feature. What is this? This is a Philips exclusive technology that creates motion compensated real-time view of the coronary arteries. Okay. When we do a coronary artery, as sir said, it's dye is going and going and going. Every time we have to down the wire, we have to inject. Dye is not a friend of kidneys. Okay, we can have a cross-induced nephropathy if we give excessive dye. So thinking of that, to reduce that, what the Philips people thought that why not produce a roadmap? And after using this condition, DCR, the facility, the dye usage has gone down to near about 30%, and the CIN rates have gone very down. Okay, so this is an example. This is a basic image. We are doing an angioplasty. You can see the wire going down. Here is the wire going down. This is a plain image. But if we do a DCR, this is a roadmap that machine gives us. We don't have to put dye again and again. This image will stay on the beating heart. You can follow these red images. Where do you want to go? In which artery you want to go? So it will help you. So you don't have to give extra dye every time, putting dye. So we can follow this roadmap and we can complete our procedure. Similarly, in the right coronary artery also see, we don't have to give a dye every time. It is giving us a real-time guidance. And we are navigating with confidence all the arteries. So this is the facility that is only available with our machines and it is not available in this region. So we have acquired this feature in our
It
catalog.
was introduced with our machine. I mean, nowhere else in India they have. This is the first one?
Yes, yes.
Or the second one? This one.
We are the second one in India.
That's what-
Yeah.
You can do PCI patient who are suffering from leukemia.
Yeah.
That is to stand and shock.
Yes, yes. So world has moved to conventional angiography to image-guided PCI. We nowadays using more of image-guided PCI. There are two softwares, two modalities. We have IVUS, we have OCT. IVUS is intravascular ultrasound and OCT is optical coherence tomography. We have acquired the IVUS part in our cath lab. OCT is still we have not acquired, but we'll soon get it. But IVUS is with us. So why image-guided PCI has to be done? What are the benefits of image-guided PCI? It helps us in three stages. First, it is a pre-intervention assessment, lesion preparation and stent deployment, and assessment of post-procedure endpoints and complications. How does it help in pre-intervention assessment? We can assess the plaque composition, lesion characteristic, whether it is a calcium-rich plaque, fatty plaque. Then we can always identify the reference segments where we have to place a stent, and of course we can choose the sizes and diameter of the stent where we have to place. Lesion preparation, of course, it will tell us the landing zones, it will tell us if there is a calcium, whether we have to use a cutting balloon or not, whether we have to use atherectomy, rotablation. So it will help us if we do an intracoronary imaging. And of course, the strategy, it will determine the success for the preparation strategy. And of course, post-procedure. It is very important, once you put a stent, sometimes it happens is your stent is not properly expanded. 2-3 months later, after doing index angioplasty, patient will come to you, chhati mein dard ho raha hai. We take him to a cath lab and we see under-expanded stent. That is very frequent if we don't do an image-guided PCI. Intravascular imaging helps us in stent optimization. We can check whether our stent is under-expanded, whether it is deformed, or whether it is malopposed. Okay? We can identify dissections, hematoma, and we can also identify whether we have missed a lesion or not, area where we had to put a stent. We can identify the geographic miss. Okay? This is a paper from New England Journal of Medicine that came out in May 2023. We did a trial of more than 1,600 patients, and that it was done in South Korea. It was a 2:1 trial in which they randomized to one arm to IVUS and one arm to angiography, PCI. And what they concluded was, among the patients with complex coronary artery lesions, intravascular image-guided PCI led to a lower incidence of composite of death from cardiac causes, target vessel related myocardial infarction, and clinically driven target revascularization than angiography. So now we have proofs. Earlier we didn't have any proofs. Now we have trials, we have randomized control trials, we have meta-analysis. And of course the world is talking about it. These are the 3 well-known intervention cardiologists from all of the world. One is from US, one is from Middle East, and one is from Europe. All are saying, just do it. Intracoronary imaging, just do it. Why? It has shown to be decreases target failures rates by 31% if you compare it with angiography. So everybody is provoking and vouching for intracoronary imaging.
Not necessarily for that.
Yes, we can do it in every case. Yes. So how does, as you were saying, how does IVUS helps? It is in helping us in deciding the PCI strategy, vessel interpretation, length of the lesion, plaque composition, of course, to evaluate this stenosis, Then in bifurcation lesions, left main disease to objectively quantify the stenosis. In advanced technologies, and of course instead of instant re-stenosis, when your stent has blocked, what are the causes of instant re-stenosis? And of course for final evaluation, luminal expansion. These are the certain examples in PCA strategy. You can see this is the IBIS image of a coronary artery where we can see the visual cross-section area, we can see the stenosis area, and we can 100% accurately tell what length of stent is needed, what diameter of stent is needed. Okay. In case of bifurcation lesion, it can tell us while putting a stent whether a plaque will shift to another artery or not. It allows us visualization of plaque location, definition of plaque characteristics, and obviously risk of plaque shift. Sometimes it is not always plaque. There are some unusual lesions going on in your coronary artery. In this slide, here you can see if we went by conventional angiogram, we won't have known that in this case there is a intimal dissection and submural hematoma has become. Okay. There is no plaque in the coronary artery, but you can see there is a separation between the media and adventitia, and there is a blood accumulation. So it is submural hematoma. Okay. So it is the region of the unequal lesion morphology which we cannot see from the conventional angiogram. And of course, complete apposition, complete expansion, appropriate stent result. It is very important. Here you can appreciate the stent is malapposed. If we would have gone by angiographic image, we would have not known that the stent is properly expanded or not. And these patients come back with again stent thrombosis and you will have infarction later. So this is a slide from a very famous interventional cardiologist from Italy. And what he has been advocating is that, supported by evidence from clinical trials and meta-analysis, IBIS consistently showed substantial reduction in cardiac events. So he's pushing for class 1A recommendation, at least in cases involving complex lesions. He's also advocating should be done in all cases, but at least in complex lesions, it is a class 1A recommendation that image-guided PCI has to be done. There is no battle between OCT and IBIS. They do not confront each other, they just augment each other. So we can't say that OCT is better than IBIS, they both complement each other. And just for the information of the audience, Himachal government has given the provision of IBIS in the HIMCare cards, so we don't have to worry about the finances also. We have the provision of intracoronary imaging through government also. This we already know after PCI has to be kept in 24 hours in CCU. You have to check an echo post procedure to look for biventricular function to exclude early post-infarct complication in the form of ventricular septal rupture, MR, and of course DAPT post procedure we already know in stable patients we generally give it for 6 months, while in ACS patients we continue it for 1 year, and if there is any extensive disease and if the bleeding risk is less, we can continue for more than 12 months also. This we often forget, the role of ICD. This has not been taught to us, but we need to know this also, that ICD has to be looked upon in patients who do not improve despite stenting, and if they are in a symptomatic heart failure, and if the ejection fraction is less than equal to 30%, 35%, opting therapy more than 3 months, at least 6 weeks after admit, we should go ahead and consider taking better an ICD, as it can prevent the risk of sudden cardiac death. Just I'm coming on the last slides of my presentation. This is the basic things, how we can, there are 8 steps to prevent heart disease and stroke. We have to know our risk. What is the risk in asymptomatic individuals? Now we are sitting in an audience. Everybody can calculate their risk score and talk about that. Eating a healthy diet, more of plant-based diet, whole egg yolks, and of course limits we can bring refined carbs, physically active. So this was the score I'm talking about. We have to identify the risk factors, whether you have hypertensive diabetes, cigarette smoking, family history of cardiovascular disease, family history of high cholesterol, CKD. You should get your lipid profile checked, and if your lipid profile is LDL is more than 190 milligrams, you have to check risk based on the age. If your age is between 20 to 39 years, you can get an informal CVD risk assessment. There are certain risk enhancing factors also. Here we have risk factors, but there are certain risk enhancing factors also where we have to check it. I'll discuss it in the coming slide. Then, if it is age 40 to 75 years, we have to check the 10-year risk. 10-year risk and a 30-year risk. Both calculators are available online. We can check our risk. And of course, with age more than 70 years, we have to check for a clinical risk assessment and risk discussion. If you are coming in a borderline risk or intermediate risk, when your 10-year risk is 5 to 7.4% or intermediate risk is 7.4 to 19.9%, you have to calculate further 30-year risk. Okay. If it is more than 39%, you should start patient on a statin, on aspirin, and advise lifestyle changes. If the risk is less, we can reassess the risk at the age of 40 or 4 to 6 years. I was talking about risk enhancing factors. These are the risk enhancing factors you must know. Family history of premature ASCVD, metabolic syndrome, primary hypercholesterolemia, CKD, lipid biomarkers, persistently elevated triglycerides more than 175 non-fasting, and of course if your HSCRP is more than 2 milligrams, your lipoprotein A more than 50 milligrams, and ApoB more than 130 milligrams. And of course when your ankle bacon index is less than 0.9, these are added risk enhancing factors. Of course, watch your weight, live tobacco free, manage your conditions, take your medicine regularly, be a team player. Know your numbers. You should know these numbers, right? Your BP should be around 130/80. Your fasting sugar should be below 110. HbA1c should be below 7. LDL below 100. Ideal weight should be height in centimeters minus 100. And waist circumference should be less than 50 centimeters of the height. Okay. Other numbers which have to be kept handy is your ambulance, your doctor, and a neuro hospital with cardiology and cath lab facility. You should know these numbers also. This thing we have discussed, nothing much in this. This is a very common slide and common question which is asked in the conferences, that how much salt beverages we can have. We can have at least daily 2 liters of water, up to 3 cups of tea or coffee, up to 1 to 2 glasses of wine or 1 can of beer, and up to 5 grams of salt and up to 10 grams of chocolate. It is recommended we can have that. This we already know, 150 minutes of activity, weight training, move more, sit less, and of course cardioprotective effects of exercise we already know. Anti-atherosclerotic, anti-arrhythmic, anti-ischemic, anti-thrombotic, and psychological. Okay? Quick.
I just wanted to, because this concerns one of the reasons whom I know very dearly. A person with no, not athletic heart syndrome, I'm saying athlete in the sense that he can run, regularly he does, actually he's a real person, 10 kilometers in 1 hour. That kind of person, regular exerciser. Now, non-smoker, no real family history, just hypertensive. I think you know the person. Hello. On antihypertensives, well controlled for the last few years, and on atorvastatin. Now he's a doctor, he's a vascular surgeon, and he has the symptoms of chronic stable angina, effort angina, over the last for the last 3 months. He doesn't believe that because he stopped running, he was not able to run. He couldn't imagine that with that kind of exercise he can have atherosclerotic heart disease. His workup is still pending. What's your thought on that?
See, we have discussed this case previously also, sir. It is not 100% surety if you are exercising well, you are away from the heart disease. There are certain genetic factors, especially South Asians and especially Indians. We are more prone to having heart disease. We have something in our genes that there is no explanation as such for that. We are working on that. But South Asians and especially Indians, sometimes I've seen cases, marathon runners, they complain of effort angina when we take them to a cath lab and we see huge plaque deposition. So we cannot predict this, who person will develop, but at least we can check the things pre-hand in the form of, if you want to be pretty sure, we can obviously go ahead and do a HSCRP apolipo-B, lipoprotein A, and of course, more than 40 years of age. There is a very controversial statement was given by Dr. Devi Shetty recently from Bangalore. He said, post 40 years, you should get at least CT coronary angiogram at least once in a decade. You know, when you CT coronary angiogram once in a decade, it is free of the disease. You are rest assured for 10 years. It gives you assurance that for 10 years you won't have a disease. But on the flip side of this, many people came up, you will give radiation to the patient, many people will come up with heart disease, many people will come up with stents and all these things. So rather than preventing the heart disease, you are giving more stents to the patients.
Was that evidence-based? I mean, have they done that over 10 years and seen?
No, it was just a statement given by Dr. Devi Shetty. Yeah. Just completing on the, I would like to share some pictures of Dr. Anil Singh. He has just come from Tokyo with his advanced AI intelligence training. So I congratulate sir for doing this training from Tokyo. And these are the pictures from Tokyo.
This is me and my wife. I'm sorry, I wanted to thank her because she set up the cath lab. Actually, 50% of the credit goes to her. And we look like college kids. This is just last month. We went to JJ University and had a formal training for 2 weeks on AI in endoscopy.
So I would like to take any questions if you have. You can obviously come and we can have a nice discussion. Sir, will. Sir, IVP, I was in to journalist common language. He will still. He knows better. Let him tell.
As I just said, मैं बिल्कुल हिंदी में बताता हूँ कि अगर आपको कोरोनरी आर्टरी के अंदर ब्लॉक है, चाहे वो स्टेनोटिक ब्लॉक है, नैरोइंग है या उसमें कोई क्लॉट फंस गया है, आप एंजियोग्राफी कर रहे हो, आपको देखना है कि वो कितना लंबा पिक्चर है या थ्रोम्बस, कितनी जगह आपने स्टेंट करनी है, उसके साथ साइड ब्रांचेस जा रही नहीं जा रही हैं. वो सिंपल एंजियोग्राफी में कंट्रास्ट रुकता नहीं है, उसको बहुत सारे सॉफ्टवेयर चाहिए देखने के लिए ताकि बार बार कंट्रास्ट में डालना पड़े कि इतनी लेंथ में डालना है, इतना लंबा स्टेंट डालना है और उसकी साइड ब्रांच ब्लॉक नहीं होगी. That kind of thing. So if you actually are able to see inside the coronaries, taking the ultrasound catheter inside, जैसे कैसे आपका एक अल्ट्रासाउंड होता है, आप उसके कैथेटर के आगे लगे तो जैसे एंजियोग्राफी कैथेटर हार्ट में जा रही है, उसके साथ में वेसल के अंदर जाएगा, उसके अंदर बताएगा हाँ इतनी नैरोइंग है, ये रियल नैरोइंग है, ये क्लॉट है, इतना लंबा है, आपने एक्चुअली इतना फिर इसको ऑप्टिमाइज करेंगे सॉफ्टवेयर से, हाँ आपने इतना डालना है. और दूसरी बात अननेसेसरी नहीं डालना, जरूरत है नहीं. सो इट दे एक्चुअली वेरी सिंपल लॉजिक दैट यू आर मोर श्योर. आई थिंक हम सब ने सुना होगा, एक्चुअली आई एम नॉट ए कार्डियोलॉजिस्ट बट देयर इज ऑलवेज काइंड ऑफ कि ठीक से जरूरत थी नहीं थी, एक की जरूरत थी, दो की जरूरत थी, तीन की जरूरत थी, हाउ डू वी डिसाइड. बहुत सारी चीजें हेल्प करता है टू टेक करेक्ट डिसीजंस इन पैरामेडिक.
सेकंड आईएवीपी के बारे में कुछ करना चाहिए.
So D is trans esophageal echocardiogram. Normal हम जो echo करते हैं, we keep a probe over there and we check the LV function, heart की pumping capacity and the some certain kind of blockages which are visible on echo. Trans esophageal echocardiogram में हम एक पाइप मुंह के रास्ते लेके जाते हैं esophagus में, और esophagus से हम एक ट्रांसड्यूसर हार्ट के पास रखते हैं. वो हमें ज़्यादा क्लियरर इमेज और ज़्यादा एक्यूरेट इमेज बताता है हार्ट की पंपिंग कैपेसिटी, और हमें एग्जैक्ट अगर किसी के पेशेंट के हार्ट में छेद है, वो हम ऊपर से अगर हम चेक करेंगे हमें उस छेद की एग्जैक्ट वैल्यू पता नहीं चलेगी. अगर हम टी करेंगे, अगर हम जो अल्ट्रासाउंड का प्रोब इसोफेगस में लेके जाके हार्ट के एकदम पास लेके जाएंगे तो हमें एग्जैक्ट हार्ट के छेद का हमें साइज पता चलेगा, क्योंकि वो बहुत डिपेंड करता है कि हमने कौन सी साइज की डिवाइस लगा. So in that cases we need a T ज़्यादातर स्ट्रक्चरल हार्ट केसेस के लिए यूज़ होती है। फॉर एग्जांपल किसी ने माइट्रल वॉल्व रिपेयर करना है, बीएमडी करनी है, बलून माइट्रल वॉल्व करनी है, रोमैटिक हार्ट डिजीज के पेशेंट्स में, उन केसेस में एग्जैक्ट लोकेशन, एग्जैक्ट फीचर ऑफ द वॉल्व और इन केसेस ऑफ जो हार्ट के छेद होते हैं उनका एग्जैक्ट साइज जानना बड़ा जरूरी होता है। तीसरी चीज इंट्रायोटिक बलून पंप। हमने कई बार देखा है हमारे पेशेंट्स को फोन आते हैं कि हमारा पेशेंट का बीपी ऊपर नहीं जा रहा, पेशेंट का बीपी मल्टीपल दवाइयाँ चल रही हैं, आइनोट्रोप चल रहे हैं, बीपी वही 50-60 पे बैठा हुआ है। बलून पंप क्या करता है, एक बलून होता है जो हम एओर्टा में डाल देते हैं, एक फेमोरल रूट से यहाँ से जाते हैं और एओर्टा में डाल देते हैं। वो क्या करता है, जब वो एक एक्स्ट्रा सपोर्ट देता है हार्ट को इन ए डायस्टोलिक पोजीशन। उससे क्या होता है, जो आपका बीपी थक से अगर 50 चल रहा है तो 100 पे पहुंच जाता है। It augments the coronary perfusion and it augments the blood pressure of the heart. ये एक मैकेनिकल तरीका है शरीर में या हार्ट का बीपी बढ़ाने के लिए। उससे हमें फायदा क्या होता है कि जो हम दवाई देते हैं उसके साइड इफेक्ट बड़े होते हैं कि किसी की किडनी में फ्लो नहीं जा रहा, किसी का पेशाब कम हो रहा है, ये हो रहा है। आईबीपी से क्या होता है, जब ऑगमेंटेशन होती है, बीपी बढ़ता है, तो ये सारे साइड इफेक्ट नहीं होते। तो ये हमें जब कोई कॉम्प्लेक्स केस करना है, कोई फॉर एग्जांपल इमरजेंसी पेशेंट आ गया, बीपी 60 है और पेशेंट को हार्ट अटैक हो रहा है, ऐसे केसेस में अगर हम आईबीपी डाल के अगर पेशेंट का हम कोई स्टेंट करते हैं, कोरोनरी एंजियोग्राम करते हैं, तो उसमें हमें एक एडिशनल सपोर्ट मिल जाता है, हमें आइनोट्रोप की जरूरत नहीं होती और पेशेंट को भी इससे बेनिफिट होता है। ये आईबीपी आई थिंक इस रीजन धर्मशाला सिटी में तो है ही नहीं, कांगड़ा में भी बहुत कम सेंटर्स में आईबीपी और जहाँ पर भी ज़्यादातर वो यूज़ नहीं करते हैं। तो फॉर दैट रीजन भी थॉट हमें आईबीपी अपनी कैथ में रखना बड़ा जरूरी है। Yes, we have.
Dr. Mead and Dr. Singh, thank you very much for this wonderful presentation. And I think that Apex Heart Care Center is really bringing some new facilities here in this region. I had patients who actually needed an ICD, but because there was no transesophageal echo available in the region, so the patient had to go outside this region. So I think this facility is really, really important because we have a lot of people with arrhythmias that require ICDs but can't be put in because of the lack of transesophageal echocardiogram. The other thing I wanted to say was that I had a patient also who had a very significant LED blockage. And the cardiologist actually couldn't clear this blockage. But he did tell me that this patient requires rotablation. Only after questioning the cardiologist, he only told me that. So I want to find out if Apex now can do rotablation.
We'll do it very soon, sir. We are still building up a cath lab. We'll bring a rotablation machine with us also. But nowadays, sir, we have also come with a new technique of intravascular IVL, lithotripsy. It is much more safer than a rotablation and much more beneficial to the patient also. It works on the principles of giving ultrasonographic pulses to the calcium. The whole purpose is to break the calcium. Rotablation is a device, it's called a burr that goes inside the coronary artery and it just breaks the calcium so that we can get a proper expansion of the artery. Similar work is being done by an IVL also in a much safer way and a much in a cost-effective way.
This lithotripsy is a EHL hydraulic lithotripsy or laser? We have two kind of.
It is ultrasonography.
Ultrasonography.
Yes.
You can order it tomorrow. I have both EHL pharmacy.
Iris? IVL is not in hip care as of now. Balloon cost, it is only the costing of the balloon that is to be there. It is around 1,20,000 balloon for the patient, but it is a safer thing as compared to rotablation. In rotablation, we have frequent slow flow and no reflow, but in IVL we don't have these complications. But the patient has to charge a bit for the balloon, that is around 1,20,000.
There are some patients who are not suffering from SCABI, they don't need PCR.
Yes, it is.
Yes.
Yes.
It's very difficult for people to save them. So in that, IVL
IBP, yes.
This is my question. This is an expensive procedure.
IBP,
How can we buy the typhoid level?
IBP is not very expensive. IBP will cost the patient just 45,000 to 50,000 extra. IBL is calcium modifying agent. IBP will cost only 40 to 50,000 extra to the patient. It is only the cost of the balloon that patient has to pay, and it remains. The balloon is there for 2-3 days. So it is only a one-time cost of 45 to 50,000. Yes.
It is not a permanent solution.
Of course, we
we just
are just yes.
transplant and
Yes,
do
yes,
some
yes, of course.
I would like to congratulate if this is very wonderful facility you are providing to the patient, because we are losing the patient and we have to sometimes back to another cities.
Yes. So, any more questions? Yes, ma'am. Yes, it's a very good question you asked, ma'am. In our machine, we have what I hope we already know that we measure radiation in the terms of gray, milligrays and air karma and all these things. In our machines, we have a very focused planar imaging on the patient. In the previous generation machines, the C-arm used to rotate and there was no panning in the previous machine. Panning means you just reduce the area of radiation only to the heart. In the previous machine, you had a big square and all the radiation goes to the operator, goes to the patient. In this machine, we can pan the radiation only to the heart, and there is a decrease of radiation by at least 50 to 60% for the operator as well as for the patient. So that is a very good. Radiation is the enemy of a cardiologist. As well as for the patient, patients, and as being a cardiologist, we see a lot of fatigue post-procedure in earlier days. But since the time we have started working on this machine, the fatigue level has gone down, and of course, radiation level has gone down. We are much more safer in terms of.
Okay. Now you are able to do this PCI in those people who are hemodynamically unstable.
Yes.
In that case, you are using this
IVP. We'll put an IVP and then it take the.
At what level of azotemia do you do this PCI?
See, azotemia.
Because this is a big barrier for us.
Yes.
Due to this azotemia,
Yes.
we are not able to get.
See, we can. What we can do is, if a patient suppose has a level of creatinine around 2, we can still go ahead and do a PCI. We can obviously reduce the dose. There are two agents, two kind of dyes. In azotemia patient, we use a special dye which have low osmolar weight that causes less damage to the kidneys. And of course, if we do an IVUS along with that, the doses of dye goes further down. So we are using DCR. If we are using IVUS, the dye dose will come down drastically. So post procedure, we don't worry about CIN. Hardly we use 50 or 60 ml of the dye. But if we do a conventional thing, dye use goes to up to 100 ml also sometimes. But we try to limit it in azotemia patient only to 50 to 60 ml.
Is it started in your setup?
Yes, we have. Yes, we have IBP and we have IVUS. Yes.
I have a very simple question, but going into the details about cardiology.
Okay.
Suppose a person like me come to PEX hospital just to screen my cardiac status.
Yes.
I just want to know what are the modalities that are available at your this PEX
Yes.
healthcare center, which can be helpful, and how it is different from other institutes which were doing all these cath lab and cardiac procedures.
Yeah, I think basic screening is same everywhere. We are no more different in doing all this thing. Basic ECG, echo, TMT, it is always there in any cardiac center. The difference comes in the cath lab. If you're coming to a hospital, obviously we'll do your blood work, we'll do the basic blood investigation, we'll do an ECG, echo, chest X-ray, and a treadmill test. Probably a stress echo also if you want.
Stress echo is there?
Yes, we have stress echo. Stress echo, there's no rocket science. We either do vitamin stress echo or we do exercise stress echo.
But most of the people we are just doing PMTs and all.
PMT, yeah. We do have a stress echo facility with us also. So that is there, it is available in all the centers. The difference comes in the cath lab. When you have all the modern equipments in your cath lab, where you can have an edge over other cath labs in the form of intracoronary imaging, which is still lacking in our region and people don't frequently use that. And of course, IVP is a game changer in a cardiogenic shock patients. We do a frequent use of intra-aortic balloon pumps and we can save lives. That is the only advantage we have over other cath labs in terms of imaging, hemodynamic support, and of course our efficient heart team is there 24/7. I've seen in various centers, people don't take up cases in the night. A patient goes to a center where a patient has a heart attack, patient has been kept on a night, okay, we'll do an angioplasty in the morning. And in that sense, I think we have done various cases in the middle of the night also, we have seen various steps.
So IVP has been started in this?
Yes, we have. We have IVP facility, we have IVP support, we have.
I just want to know what is the level of evidence regarding IMP?
Very right question. Various numerous trials have been done, and it has been shown that, of course, you must be knowing there are other devices also, an impeller device that is a much better support than IBP. But the only problem with the impeller is the cost issue. IBP, as you rightly said, various trials have been done, various studies have been done. It has been found that it does not improve much in terms of in cardiogenic shock patient the outcomes. But we as a cardiologist have been trained to use this. When we see a patient in a shock, cardiogenic shock, we are tempted to use that. Why so? If we don't use it, then we are in a guilt. Oh, we might could have used it, we could have saved the patient, we could have raised the BP up. But coming back to your question, all the trials as of now are the negative trials. IBP, of course, it is, if we do a PCI with or without an IBP, in trials it has shown it has a neutral effect. But in real time scenario, in real world, if we go ahead and do a patient in a cardiogenic shock and if we can raise the blood pressure, it is always beneficial to the patient. And of course, we can save a life with the use of that. But as of now, in all the trials, all the trials have been neutral as of now. I think, sir, you can come and take over.
So I think you have covered everything wonderfully. My only question always remains is, now it's easy for intelligent physicians to think about these things. She knows about everything, what cardiologists need and what emergency would need. But what would be, I think there has to be a message for non-physicians, people or non-cardiologists. We'll say Dr. Rajendra Thakur, when he will suspect or say कि तुम चले जाओ ये investigate करना है. When it is such a see, there is one preventive aspect, there is one elective cardiology aspect, and there is emergency aspect. There is something you want to say?
I think it depends upon.
Because is it shows you nothing? Sometimes we can mix symptoms. So what exactly you tell them?
See, the most common symptom is angina on exertion. We already know that. Dyspnea on exertion, difficulty in breathing on walking. When you go up the hill, when you are, you cannot walk, or you cannot go up the hill from your previous capacity. These are the signs and symptoms that you should just ring your bells in your ears that now I should get my cardiac evaluation done. And of course, you have strong family history. When you have a strong family history, your first degree relative has had a history of MI or certain cardiac health. In those patients, you should get your early check-up.
I think it's time. Any more questions? Yes.
Case where we're suspected to have ischemic heart disease, we have about a term called angina equivalent. So we think should look at angina equivalents also. Like there's quite a lot of patients who come with just syncopal attacks or some kind of infatigability. I've seen patients coming to me with leg pain. They are walking, they have leg pain. We think that it is probably an intermittent claudication, claudication which is happening. But it's actually an angina which is happening. Some people come with jaw claudication, one patient. So these are the angina equivalents we should think of. We should not always think of dyspnea and chest pain as markers of ischemic heart disease.
Something like that, I was thinking. So the thing is, how often you find people we miss heart disease or forget sending in an emergency? Like how often that does it happen? Patients come a little late. Couple of days back you said that somebody was a little late for microtimes and for long time. So I mean that's obvious that they have not been tested. So you can't generalize it. But generally you have to say, but you know, non-cardiologist actually it's difficult to simplify it. But you actually suspected all the time. Another I will not read before. This concerns Dr. Anurag Khanna. No, it's a question of how a non-cardiologist. Like he's my friend. No, he went and for cardiac, he got a stent inside. And Dr. Anurag Khanna I'm talking about. He went ahead and got a PCI done. Then he didn't remain so well or so fit. You will expect that everything is gone. There's no angina now, and he should be back to his badminton. He kept on complaining of symptoms. Then you explained or somebody explained that it was actually microvascular angina, which means are we able to decide the contribution of stenosis plus thrombosis versus spasm versus microvascular angina beforehand, before we start putting the stent? Because then you're doing fine now. So how about that?
There are no objective tests to quantify in cath lab as for now to detect microvascular angina, but we can, as you are talking about coronary spasm, we can give during procedure acetylcholine and we can check for a coronary spasm. That is the facility we have. But to check a microvascular angina is at the level of microvessels, so it is very difficult to get there. It is not done in India as of now. But of course, we can do a physiological assessment also in certain cases with the help of FFR or IFR. Whether you need a stent or not. So that facility we have, but to modify microvascular angina we don't have.
एक परसेंट अभी ऐसा है कि लोगों को पता आप ERC भी करते हैं. What are you doing in gastroenterology? आप थोड़ा बताना चाहिए.
I think let it save it for some other day. Okay. Right now I'm more in the cardiology mode. So I think we take the permission now to get
Yes, sir.
Okay. So I think I need to thank you once again. And what else we have on the menu now? Some dinner and drink. And I've got to introduce these two lovely girls. They are my assistants, nurses actually, for last 6 years. And she's from Lisa, and she's from Pali. And she's what do you call that now? You can always make her do the nutty. She's I love nutty dancer. She can do it right now. Thank you so much. Thank you so much. That's a great example.